I'm usually saying that this time of year, there's a lot of conferences.
All right. I'd like to call the meeting to order, and Police Secretary call roll.
Director Kim is absent. Director Sorrell?
Present.
Director States?
Here, present.
Director Webster Cross is absent. Chair Buck?
Present.
And for the record, Ms. Merriweather? Present. Thank you. You have a quorum.
Thank you. Next regular meeting is March 20th at 9 a.m. on Friday. And Secretary, do we have any speakers registered to provide virtual in-person testimony?
We did not receive registrations nor any written testimony.
Okay, thank you. Well, good morning, everyone. Glad to be here with you all. We'll start with our action items. Appointments, reappointments of Stroger Department and Division chairs. I'll ask Dr. Lawrence Smith to present that, please. Thank you. Okay, good morning.
Good morning, directors.
Good morning.
Good morning.
So I have one this morning, Dr. Trevor Lewis, for Chair of the Department of Emergency Medicine. Dr. Lewis, and this is for a reappointment. Dr. Lewis joined Cook County Health in 2002. He was initially appointed chair in 2020, and he completed his emergency medicine residency here at Stroger Hospital. He's a noted lecturer and author, and happy to request approval for his reappointment for the Chair of Department of Emergency Medicine.
Thank you. Are there any, questions? Motion to, do I have a motion to approve item 3A, proposed Stroger Hospital Department Chair reappointment?
Move. Second.
Motion's been made and seconded. Any questions, or comments on the motion? All right, hearing none, all in favor say aye.
Aye.
All opposed? Nay. Motion carries. Thank you. We'll go to, item 3B, Executive Medical Staff of EMS's Stroger Hospital Medical Executive Committee, Provident Hospital Reports, action items. So, we have Dr. Paul Allegretti, Provident MEC President, will present Provident Medical Staff action items.
Good morning, everybody. Paul Allegretti from Provident. I am here to ask for approval for our appointments and reappointments for Provident Hospital. These were approved by the centralized credentialing committee on January 22nd, and then MedExec at Provident on February 6th. I'm here for any questions or comments.
Any questions? Okay. Thank you, Dr. Allegretti. We have Dr. Thomas Petriancos, Stroger EMS President, is unable to attend today, the conference. So these were sent in, for Stroger Medical Staff action items were sent in advance of the meeting, being presented for the committee's consideration. Motion to approve item 3B, the proposed Stroger Hospital, Provident Hospital Medical Staff appointments, reappointments, changes.
Move. Second.
The motion is, and has been seconded. Any discussion on the motion? Hearing none, all in favor say aye.
Aye.
All opposed? Motion carries. Item 3B passes. I'll go to item 3C, is the minutes of the January 16, 2026 QPS Committee Meeting. These are being presented, and these were approved by the board at the January meeting. Are there any corrections to be made? And if not, motion to accept item 3C, the Quality and Patient Safety Committee Meeting minutes of January 16th, 2026.
Second.
It should have been motion has been made and seconded. Any discussion on the motion? Hearing none, all in favor say aye.
Aye.
All opposed, say nay. Aye. Yes. Ayes have it. And, right, thank you. And before we go to the next set of items, I want to also recognize Chair Raul Garza, who's joined us remotely. Thank you for joining us.
And Director Harrington.
Thank you.
Director Harrington, good to see you. Thank you. All right. We'll go to Operational Excellence Dashboard Goals and Tactics. Well, that's presented, and then each of the site reviews. So, thank you. Stroger Hospital site review with Dr. Cost and Catherine. Thank you.
Thank you, Chair.
Good to see you the other day.
Yes, thank you. Thank you, Chair Bond, and good morning, directors.
Good morning.
Okay, so before us, we have the Stroger OpEx dashboard. Moving to, let's go forward 2 slides, Debbie. Thank you. All righty. Taking a look at our dashboard, when we look at, so we still are following our 4 areas of focus: patient experience, clinical outcomes, readmissions, and throughput. Looking at our provider communication, we are in a positive trend, starting the year off with 87.50, which is above our stretch goal for our physician domain, but just slightly lower than last month, but again, still in a positive trend. Our nursing communication, starting off the first of the year with our nursing domain slightly lower than the goal, coming in at 70.07, top box for January 2026 against the goal of 73. I do want to highlight that the nurse continues to focus on communication, anticipating our patient needs, staffing, making connections with patients and families, and again, trying to continue to move those scores. As we look at our mortality index came in at 0.96 for December, under the 1.0, which is good, but we didn't quite make our goal, which is 0.80 for 2025. We ended at 1.03 mortality index for the year, and we have lower observed deaths compared to our peers, and also lower expected mortality, which impacts our index. So a
Question on this one. Is there any insights around what was happening in February and April 2025 that compared to, I guess, most recent numbers in terms of the meeting?
Well, I will say a lot of work is being done on physician documentation and coding. There is a multidisciplinary group. They are reviewing each of the cases and looking at themes and recognizing, where we have opportunities. There's been a focus on, the physician handoff. There's also a new nursing infrastructure to get feedback from our nurses, because obviously nursing is going to be critical in that as well.
So, Dr. Bhatt, we started reviewing all mortality cases 100% last year. As Danica mentioned, we have a multidisciplinary committee that reviews it. But in addition to everything Danica mentioned, I would also add that a huge piece of our focus is around physician education. As we have shared with the board in the past, one of our findings from all the reviews we are doing is that oftentimes it's the clinical documentation that is bringing our scores down. So team has been focused on very targeted education for physicians. On top of that, they are also, they have implemented for certain areas smart texting, that allows physicians, helps with, better coding. As we, bring on the new EHR system, there would be an additional focus on making coding easier for our physicians, which would definitely help us with that too. As we are relaunching our peer review process that Dr. McCormick is leading, there would be additional focus on mortality as well. So within the next 2 to 3 months, we hope to bring to the board a more comprehensive plan on all things peer review, including mortality, which we think would definitely help us identify additional opportunities for improvement.
When you talk about documentation, you're talking about data that rolls up based upon individuals documenting that something happened. Do we know if there are individuals that are outliers relative to that data?
So we are really, when we talk about mortality, we are looking at observed versus expected. That's where our opportunities are. For the patient population that we serve, there are some expected mortality that, we are benchmarked against, but our documentation doesn't always help us when we try to do the comparison between what's observed versus expected.
Thank you.
It's also very multifactorial in the sense of there's kind of what's happening at the bedside, what gets translated into the chart, what makes it out of the chart onto the claim, what the payers then acknowledge, right? So there's a whole kind of, and we have opportunities kind of at every step there. So we're working obviously with quality and documentation. We're working at, as Raji mentioned, the whole peer review process and quality review, mortality review. That's kind of the closer to the bedside, what we're doing to find improvement opportunities. We're also working on the rev cycle piece where, we're finding that sometimes the codes aren't making it all the way through. So we're not getting credit sometimes for exactly how sick some of our patients are. So a lot of different steps that we're having to address.
Okay, moving into our patient safety indicator, our PSI 90 came in at 0.85 for December 2025. The indicator did not meet the goal, which was 0.90. And so we did see a 3.6% decrease when we compare 2024 to 2025. Moving into our sepsis bundle compliance, we ended the year with our best monthly compliance at 61.54. We're, trying to get to the target. We are not yet there. The target is 67%. So there obviously is a few things that are focused on antibiotics and blood culture related to sepsis. Next week in the ED, they're moving forward with the soft ID, which will provide the blood culture right away instead of it having to be sent down into the lab. So that's important so that we don't avoid any fallouts and we can track real time. Let's see. Looking at our readmissions, moving into our COPD rate and our post-hospital appointment days. I know that there will be a presentation in closed session related to our readmissions, but the COPD readmission rate was high in November for this month. And then also our post-hospital appointment days, we're still meeting the average days of post-hospital appointment at the 14.30 days for patients admitted and discharged to be seen within 14 days, which is below our stretch target. Moving into our throughput, so a lot of work is being done in our the GMLOS, the geometric length of stay. The LOS average variance in days is better than the stretch for December. And then also our ED, for ED discharge patients, December came in higher than months prior at 316 minutes, median for patients discharged from the emergency department. Obviously, a few things that are happening in the emergency department. They're looking at reinforcement of their pool-to-full model so that they can identify patients right away that need to obviously go back. There's a strong partnership with the ancillary areas as well, and then early diagnosis in the lab work expansion in the emergency department has helped there. Let me pause to see if there's questions.
Is it possible at some time to get the information about the mortality by sepsis? Because I know antimicrobial resistance is a factor now, and also the time. Because sometimes a patient will stay at home thinking this is, it was an infection, it's nothing, and they don't make it in time. So it's the education of the patients, all patients leaving the hospital, but also then the time to get to the hospital, and then the antimicrobial resistance is very prominent.
So Ms. Meriwether, we will definitely bring that team back to explain that data. We are performing very well compared to national benchmarks when it comes to sepsis treatment. The numbers we present here is, as you know, just related to bundle compliance, which is part of the overall picture, but it's a small piece of the bigger picture. So we will definitely bring that group, maybe as early as next month, to provide the current, data performance of everything sepsis related.
Thank you.
Thank you.
Can I add a couple more points?
Absolutely.
Just so the board knows, the sepsis, even though we haven't met our goal yet, our sepsis bundle performance compliance performance has really gone up in the last few months. This has been a tough goal to accomplish for us because, if we don't perform, we are not completing all the elements of the bundle, then we don't get the credit. So it was important for us to hardwire those expectations into the day-to-day clinical performance of our clinical team. So we seem to be getting really close to, holding those, behaviors down, making it more consistent. And, as Danica alluded to, we are also adding the barcoding of the labs at the point of collection, which we had shared with the board in the past that, the time delay, the documentation of time collected and time received, that was kind of, hurting us a little bit. So with the introduction of that technology, we are hoping that documentation opportunity is addressed.
Yeah, thanks for, I was gonna raise that point. Thanks for sharing that. Appreciate, the hard work on driving that forward. Because I think the other thing is, that if we don't do something different, how do you get to improved outcomes? So the system's designed to achieve those results that it's designed for. So continue to be helpful as we continue looking at these numbers. Any particular changes to the system that's trying to drive better outcomes would be good for this committee to be aware of.
We will try to bring them next month and, share a comprehensive report on everything we've been doing and the timeline for additional interventions as well. Readmissions rate, we understand board had questions in the past, so we have a team here to present later in the closed session. Thank you.
Thank you. Any other comments, questions? No? Good. Okay. Nothing else. All right, we'll have Dr. Ronald Turner, Providence Hospital Site Review. Thank you.
Good morning, directors.
Morning.
I want to review the Provident OPEX committee dashboard this morning. For this month, we have two targets that are better than stretch, two metrics rather that are better than the target but less than the stretch. We have one metric that did not meet target but is better than baseline. And we have one metric that continues to be less than baseline. Next slide, please. The first one is the patient experience, the survey return volume. Despite many efforts put to move this metric, we've been unable to make change. We've ended the year below the baseline the previous year. We've included post-discharge phone calls during the discharge, both by the nurses and the physicians. Patients are reminded to complete the surveys. And despite that, we still have not been able to move the dial on this one. I know we're supposed to be at some point switching over to an email survey, which may improve the results, but right now the mail, just the mail survey has not given us the results that we want and the results that we need, so we can make changes that will improve the patient experience. With respect to the next one, the rolling 12-month top box with nursing communication, we've met the target, actually exceeded it. The target for the month is 80, and we did, for the rolling 12 months, that's not right. The stretch is 83, the target is 80. We're at above 80, but not at the target, except, not at the stretch rather, except at the, in the month of January, we did exceed the stretch goal, as you can see. Continue to work on that, I think, through the efforts of our Chief Nursing Officer, Mike Noonan, the changes that they made in the nursing with respect to hourly rounding, and the house administrator also rounding on the patients, and made a difference with respect to the communication. The next one, rolling 12 months for sepsis, we are better than baseline, but not at target. We have a low volume in these cases, not that making that as a reason for us not meeting the target, but with such a low volume, just one is often can have a severe impact on the results. We did not have any data for the month of December for this metric. Moving on to the rolling 12 months for inpatient falls. This we continue to do really well with this due to the changes that nursing put in place. The target was 16, the stretch was 15, and we continue for the last 4 months to be at 12 with no falls in December and January. Again, that's it's resulting from the work that our nursing department and focus that they put on this.
What kind of measures did you put in place that resulted in?
Again, hourly rounding, we have actually put patients who are at increased risk for falls in rooms that are closer to the nursing station, bed monitors that we have there, and just raising the level of consciousness of the nurses that we. I think as we brought this metric down, that encouraged more teamwork to continue this effort to bring it down, to keep it this way. The next one is the rolling 12 months from decision to admit to depart. With this metric, we did surpass the stretch goal. The stretch target was 100 minutes. We were at 99 and 98 for the last 2 months. However, looking at January, for the month, we are above the target at 139 months. We're looking into that. Our census overall for the month, but we did have some days where we were really busy in the ED. That may account for that. With respect to left without being seen, we continue to do well below the target for that. The target is 2%. We're at 1%, and continue to be at that. I think our ED is considering lowering that to the 1% since we've been hitting that so repeatedly. And that concludes any questions.
Can I add a couple of comments? Board might have questions about how we are, working on integrating additional ways of communicating or getting the survey responses back from our patients, not just for Provident but for Georgia too. We will bring in a link next month to present on everything we've been doing so far to get better information from the patients on, sending surveys out electronically. So there's a lot of work that has been happening, but we will bring, a more in-depth presentation to the board. If there is, in addition to everything Dr. Turner said, the nursing at Provident has been strengthening the rounding and hourly rounding, and also registration has been also involved in explaining to the patient as to why we are trying to collect demographic information and their addresses, which we know sometimes can be very sensitive, especially in the current landscape of this. So, that effort is ongoing.
Appreciate the continued focus and hard work. Thank you.
And the left without being seen, it is a wonderful
They're doing an
achievement,
amazing job.
Thank you, Dr. Turner and Craig Williams, the CCH Cyber.
Thank you. Good morning. If we go to probably the last slide, Deb. No, one before that, sorry. Good morning, Craig Williams, Chief Operating Officer, reporting on our ACHN work. The first 3 metrics are around patient experience. What I would say is, I'll go through each one. Around staff working together, we had gradual improvement, but we were consistently below target, but better than baseline from last year. We did improve 3.7% through December of 25. We did have a little dip in January to 66.72. We're starting to dig in across all of the patient experience metrics. We did have a little dip during the month of January. So we're digging into the comments right now. We're really excited about some of the work that we have going on patient experience across our ambulatory enterprise. We have a new patient experience manager that works directly with Lindang. that has rolled out new posters that's creating a lot of excitement in each of the practices where they're putting their scores in, creating a lot more engagement around scores, comments, and that linkage. We've done a number of focus groups with our staff, both MAs, clerks, nurses, and MDs. And one thing specifically with the clerks, which, we've had a little bit of a pain point in that staff and getting them to engage with patients the way we want. And when we talk to them, what they describe is they have a really difficult job, which we knew. And so we're doing a little bit of work redesign with them, mostly around the revenue cycle. So right now we ask them to do a full registration, soup to nuts on every single patient, even though the vast majority of patients that come in have been financially cleared, can do that before their visit. So we're trying to take some of that work off their plate, do that electronically, so they can focus on the patients that need to be addressed when they're in the practice, and then others that are financially cleared can kind of pass go. And we think that'll allow them to have more time to create engagement. So really proud of the team and how they've dug into that. On provider addresses concerns, worries, gradual improvement, but consistently below target, but better than baseline. We had a 2.2% change in top box score over the year. Again, we had a little bit dip from 67% in December down to 65.63 in January. On care provider explains the problem condition, improvement, AMET goal for 2026, for 2025. The measure did not meet the goal, but did improve 2.9% in top box scores. Again, we had another little dip in this measure from 67 down to 60, just under 65 in January. So really studying the comments and trying to understand what happens. Most notably, many of those patient visits were probably during the month of December, which you'd think people would be in good mood, right? It's holiday season, so we're just trying to figure out what's happening there. On breast cancer screening, we had improvement, AMET goal for 2026. Measure improved 26% throughout the year. We started January at 62, which is slightly below where we ended December. But I mostly chalked that up to just some time out of office. Hypertension management, improvement in MET goal in 2025. Measure improved 10.6% across the year. And we're at 57.8, so pretty steady performance there for January. On empanelment, so you'll see on empanelment, we took a big jump during the month of January up to 123,956. Would have put us ahead of our stretch goal for last year. We actually looked at this metric. We've looked at our capabilities on our new population health Oracle platform, as well as industry standards about best practice around measuring empanelment. And so what I would say is we show great improvement, but it's a little bit of a apples to oranges compare. So what we really need to do is study this over the next couple of months and create new targets and goals based on how we're recording this data. But we think this is a much better measurement. It actually incorporates data that we're getting from the payers into how we're measuring patient engagement with our providers and that empanelment and what they believe our empanelment is.
Is the 123,000, is that individuals or is that?
It is. It's individuals that have
individual visits, but people making multiple visits.
More than 2 visits in the last 2 years, I believe, is the technical metric.
These are individuals, right?
What?
Individuals.
Yes, individuals. Yeah. Yes. Yeah. Individuals had more than 2 visits in the last 2 years. And the other thing that is part of this metric that we're trying to understand is the migrant program was part of that, and so anyone coming through that, the migrant, the 38,000 people that came to that clinic would have counted as being impaneled, and likely many of them are dropping off. So we're trying to just figure that. A lot of moving things in this number, I would say.
And it did include telehealth visits too?
It does include telehealth if they are enrolled with our PCPs, and so what it wouldn't count is people who are not otherwise affiliated with Cook County Health that just have a telehealth visit through Express Care. Yeah.
And I'm reading this correctly, that you're increasing the stretch goal now for breast cancer screening to make sure you're accommodating and increasing those numbers?
We are.
Is that still just about, 2/3 of those that are enrolled and getting the screenings?
Yeah, we're all of these metrics are going up for this year. Yeah.
Yeah,
this question on the breast cancer screening, if there is indeterminate, on the screen that requires, or something that requires a diagnostic, mammogram and ultrasound, is that covered, from a, insurance standpoint through, depending on whether it's county care or others, or is there a sense of understanding what's covered, what's not?
I think there's a good sense of understanding. Obviously, all the screening exams are covered for people who are
Yeah, but
covered.
the
But when
diagnostic
there's a
is-
diagnostic, that is based on that, that finding. So, I mean, I think we've actually had pretty strong results on recovery for the mammograms we've been doing. Obviously the birthday screening program, which also has driven some of that increase, that does, the purpose of that is to make sure everyone's getting screened, and obviously that's a big part of our mission. So, we haven't noticed, I would say, we haven't noticed a, demonstrable increase in uninsured, beyond what we're already seeing across the market.
Yeah, just, sometimes if there's not clear understanding whether that diagnostic is covered or not, people may delay care because of the cost, and that is an important, thing in terms of trying to catch it early.
One of the things that's interesting, you're screening to identify people that are early stage of disease and then help manage disease moving forward. Do you have data so that we know how that's working, how many people we identify, how many people actually get care, and possibly even some things we may have prevented because we caught them early?
I can certainly go back to the team. I know we do have that data and see if we can maybe have a future presentation on that. And the other place I think would be worth talking about too is the work around lung cancer screening, because we've increased those rates and we have better processes around biopsies within our interventional pulmonology department. So a lot of work happening in that space too.
And then is there data around colon cancer screening, and also then, as we think about younger people where the incidence may be increasing?
Yeah, that's not one of the metrics that, we have the data. It's not one of our KPIs right now, but something we could consider.
It is monitored. We do
Yeah.
track it. We can bring that information. Board is interested in seeing that.
Were there any other questions, comments?
I know that Medicare has the welcome visits. Does county care provide the welcome visits to new enrollees?
Do you track that data?
Are you talking about the annual wellness visit?
Yes.
Yes. So we have an initiative this year to increase our percentage of patients that are getting their annual wellness visit. I think last year we ended, Beth, I want to say 20% last year of our enrollees were getting their annual wellness visit, and we're targeting to get that closer to 40% this year. So big focus on that. Beth has really been leading a lot of the workflows around that.
Because the telehealth helps with the number of people to get the number out.
Yeah, we're doing, it'd be worth presenting, we're right on the precipice of making some pretty big changes around our telehealth program and really how we're trying to help our PCPs with their workload, but turning that into something that is also very patient-facing. We're not quite ready to present on that yet, but I think that would be something that would probably be interesting to this committee at some point.
So I think that's where you can have discussions about preventive care, your screening, your cancer screening, breast cancer screening, all of that can be combined in.
I'm going to phone a friend to add some color to this.
Okay.
Friend is emerging. You just say, yeah, we are name and title for record.
Executive for Ambulatory Services and the interim chief nurse executive for the system. And as Craig had mentioned, we have a couple initiatives that have been going. We've been working with value-based care in an effort to do gap closure. So we're looking at all of the patients who are coming in and looking at that preventative care to close those gaps. But we're also looking at those annual wellness visits for our Medicare patients. And so to align with that, we have that initial visit that is done, and then the annual wellness visits every 365 days plus. And that time will be spent with a nurse before a physician visit to go over everything from social determinants of health to all of the preventative care and the screening to make sure that all of those gaps have been closed for preventative care.
Do you also do the, comprehensive medication review, for the polypharmacy patients?
Yes, so that is part of the annual wellness visit, is to do that medication review.
Okay, because that's a separate one for polypharmacy. Yeah.
Our medicine clinics do have additional visits
Yeah.
specifically for, we focus a lot on the older individual that has that polypharmacy to make sure that they're getting all of the right medications, the right doses, and not taking two that are having the same action.
Yeah. Okay, thank you.
You're welcome.
And then, quick question on the empanelment of engaged affiliated patients. It's good to see the growth. Do we monitor the length of their engagement then with that empanelment or with the system?
Their overall time in empanelment?
Yeah.
You know, I'd have to go back to the team and make that query. I mean, the data's definitely there. I'm not sure that's something that we've, studied deeply. Are you aware, Raji? Yeah.
I mean, I think I just asked in relation to this previous point about care gaps. You know, are there folks falling out, that create a care gap?
I mean, we definitely do a lot of work on running lists to make sure that people aren't falling off the back and trying to get them engaged in care. That is a big initiative, as well as trying to provide better access on the front end. And then overall, it's really trying to close care gaps as they're empaneled.
Got it, thanks.
Thank you.
Thank you.
All right, we're gonna have a regulatory update, Joseph. Thank you.
Morning.
Good morning.
Morning. Here to provide the regulatory updates. I do have an update that is not included in these slides. I'll just start with that real quick. We had an unannounced Joint Commission visit this past Tuesday, the 17th. One surveyor presented for about half a day on a patient complaint. We do expect to report within the next week. Starting at the top, unannounced IDPH investigation. This is a focus on emergency services at Stroger. We did receive a follow-up from IDPH. The hospital was in substantial compliance, and this was from a visit that happened just before the holidays, December 23rd and 24th. IDPH redesignation, adult and pediatric level 1 trauma center at Stroger. IDPH approved our redesignation both as an adult and pediatric level 1 trauma center. We have valid through December of 2027. Also have IDPH outpatient dialysis recertification at Stroger. That is expected at any time. Next, we have the American College of Surgeons Cancer Registry at Stroger. We do have a virtual site visit scheduled for Tuesday, April 21st. Also, IDPH EMS Resource Hospital site visit at Stroger. We are scheduled for October of 2026. Next slide, please. We have the National Commission on Correctional Healthcare, or NCCHC, at CERMAC. This is specific for the opioid treatment program. We had the site visit this past June 24th and 25th. We did receive notification that we are accredited, and this is through August of 2028. Also with NCCHC at CERMAC, the mental health accreditation. We're applying for accreditation with a goal of a 2026 survey. NCCHC as well at CERMAC, jail accreditation. We're due for reaccreditation in 2026. We were told will not occur until at least the second quarter or later of this year. Illinois Department of Public Health, or IDPH, perinatal redesignation at Stroger. We anticipate fall of 2026. And lastly, the Joint Commission Triennial Survey at Provident. Previous visit was for 4 days, December 5th through 8th of 2023. It's an unannounced visit. We're expecting being unannounced possibly in the fall, September, October, but that being said, we want to be prepared if they come early. So we're planning to be ready as early as this June. Next slide, please. So this colorful grid is a snapshot of some of the findings during the survey. Each box represents a volume of findings, and I'll just kind of quickly run through the top 6. We have expired products at the top, which are corrected on the spot, but again, they seem to be the highest volume of findings that we're seeing. Dusty sprinkler pennant heads in the ceilings, which again, we know Buildings and Grounds has hired an organization that's going to be taking care of that. We have logs missing checks, logs being crash carts, eyewash refrigerators, such an education component. Expired hand gel, as you might imagine, some areas that have less frequency of foot traffic, the gel can expire, does have expiration dates, so we're noticing that, and we are, of course, pulling them on the spot. Next is missing preventive maintenance, which we alert clinical engineering to when we find a product that may have fallen through the gaps. And lastly, visible dust on ceiling vents. That's the top 6. Next slide, please. So what's being done for prep at Providence? So I'm get some examples of some of the work that's happening. I did a deep dive on Providence units September through November, so those 3 months, and was able to learn the units and get a good feel of the findings. We are doing a weekly multidisciplinary team round every Tuesday that will continue until the site visit, triennial. I provided unit staff at Providence a weekly self-assessment tool to self-audit their units in between the rounds that we're completing. So that's something that's available to them. We are running tracers where we're tracing patients through levels of care, where that includes both chart review and practice with staff on the type of questions the survey could ask and building comfort and familiarity with somebody looking over their shoulder, having them navigate through the chart. We are planning a mock survey tentatively right now in April. We're trying to get this squared away with an outside organization, so that'll be really helpful as far as their feedback and corrective actions that we can put together from their report. I am providing focus-specific tracers, most recently in the SPD or sterile processing department at Providence. We're doing a deeper dive into certain areas. I am working in the early stages of what's called a survey process guide, which some of you may be familiar with, which is the booklet that's been produced in previous years. We hope to get that out soon, and once the draft is completed. And lastly, updating what's called the hospital document list, which is a list of required documents, 60 documents that Joint Commission would like to have on hand within the first hour that they arrive. And we've had that obviously in past surveys. It's just a question of updating, and I'm currently working through that to get that squared away. And that's my updates as far as regulatory. Happy to answer any questions.
Questions, comments?
Yeah.
Great.
Appreciate your time. Thank you.
for the update.
Yeah.
People are happy to see you come, I'm sure.
Thank you. The committee will now go into closed meeting. Actions not expected to be taken open session after discussion in the closed session. So we need a motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120/2, 1/2/11/17. So we need a roll call vote, Secretary. We need a motion first.
I move.
Second.
Motion's been made and seconded. Any discussion on the motion? Hearing none, all in favor say aye.
Aye.
All opposed, say nay. Motion carries. Go to closed session. We have a recess.